Good morning. Thank you, Mr. Chairman. I want to thank the organization for the kind invitation to talk about subjective and objective nasal parameters, measurements, in sleep-related breathing disorders. So it's difficult to talk now after Professor Carl, but I will try to make my best. How does it go?
You have to press the green button.
The green button. Okay, sorry. All we know that sleep-related breathing disorders are quite common, and we have up to 50% of us that are snorers, and up to 8% of people, especially males, that suffer of pathologic obstructive sleep apnea syndrome. The rule of the nose, we just heard that there is a rule of the nose, and we already heard that Hippocrates was the first one reporting an influence on, of the nose on the sleep quality. In fact, he observed it in the morbis popularibus, that nasal polyps were associated with a poor sleep quality. But all of us has experience of acute rhinitis, for example, during a common cold, and all of us knows how poor is the sleep during this situation. And there are a couple of papers where nostril occlusion has been produced, and this occlusion has caused arousal, a worsening in sleep quality, and a significant nocturnal desaturation. A more recent paper studied what happens in our patients after during nasal packing due to, for example, epistaxis or after nasal surgery, and about half of these patients demonstrated a pathological saturation during the night. So there is a rule, of course, of the nose, but may we reverse it? This is a list of papers about snorers, snorers with rhinitis, allergic rhinitis, and all of them were treated with steroids, and no polysomnography was produced in these cases, so we don't have a proper sleep study. But they observed that steroids, nasal steroids, produce an improvement in sleep quality, in particular about the symptoms reported by the patients. Anyway, when we perform a polysomnography, no differences in objective data have obtained. In this other chart, we find two different papers that have evaluated the role of topical treatment in patients affected by obstructive sleep apnea syndrome. And they found in the first one, we can see that the treatment of the nose produces a significant reduction of apnea-hypopnea index, but no improvement in the symptoms reported by the patient. In the second one, the same amount of patients, they were 10 OSAS patients, were treated with the same method, topical xylometazoline and also nasal dilators, and no changes in apnea-hypopnea index was found, while subjective improvement in sleep quality was observed, a subjective one. So there is a big mess. We have different studies with different results, but as we know, and we just heard, the nose is producing about 2/3 of the resistances at the level of the upper airway, at least when we are awake. So maybe some methods for the measurement of nasal resistances or the nasal airway can be helpful in these patients. And there are few studies that have tried to assess these different measurements in sleep-related breathing disorders. And we start with the rhinomanometry. Rhinomanometry in snorers, in this case, has been found that habitual snorers, about 65% of snorers, have higher than normal nasal resistances as measured at the rhinomanometry. Anyway, only 19% of them reported nasal obstruction subjectively. Going to OSAS patients, higher than normal nasal resistances have been found in OSAS, but the number of apneas did not correlate with the degree of nasal resistances as measured by rhinomanometry. Finally, in this study, it was observed that there was a relation, a strict relation between apnea, hypopnea index and nasal resistances. And after treating the nose with steroids, we obtain a reduction in apnea, hypopnea index, also in nasal resistances. Anyway, the snoring noise and the sleep quality were unchanged in these patients. Going to acoustic rhinometry, there are two studies that obtain different opposite results. The first one, in OSAS patients, moderate to severe OSAS, acoustic rhinometry could not differentiate between patients affected by OSAS and patients in the control group of healthy subjects. In the second study, patients affected by OSAS reporting nocturnal nasal obstruction presented lower minimal cross-sectional area. What about PNIF, peak nasal inspiratory flow, has been studied as well in two different studies. And in the first one, in OSAS patients, PNIF could not differentiate between OSAS and the control group, although lower PNIF values were capable of predicting a higher apnea-hypopnea index score. In the second one, lower PNIF values were found in the OSAS group than in the control group. Recently, also POIF has been studied in these patients. This is a nice study conducted on children in UK. Together with peak nasal inspiratory flow, also peak oral inspiratory flow was performed before and after tonsillectomy in these children. Tonsillectomy was suggested also for sleep-related breathing disorders. It was found that both PNIF and POIF improved postoperatively. POIF improved by 45%. So authors concluded that both instruments can be useful to measure oral and nasal obstruction in these patients. So now we have also seen the studies measuring in an objective way the nasal airway. And still we have different studies with different results on the contribution of nasal congestion as measured objectively and the relation with sleep-related breathing disorders. So we come to our study. This is an unpublished study. The aim of this study was to analyze if there was a relationship between objective and subjective nasal parameters in sleep-related breathing disorders, also evaluating peak oral inspiratory flow. So we performed peak nasal inspiratory flow, peak oral inspiratory flow, SNOT 22, and VAS for nasal obstruction in 32 OSAS patients. 27 of them were males. The mean age was 53 years old. Mean apnea-hypopnea index was 28.8. In particular, we paid attention to the SNOT 22 questions related to sleep. So reduced concentration during the day, wake up during the night, and so on. These are the results. Peak nasal inspiratory flow and the peak oral inspiratory flow showed a marginal correlation between them, but no correlation was observed between OSAS severity and no one of these instruments. So the peak nasal inspiratory flow, peak oral inspiratory flow, and nasal patency index, which is the relation between peak nasal inspiratory flow and peak oral inspiratory flow. OSA severity was not correlated to SNOT-22 score, nor to the SNOT-22 questions related to sleep. But if we perform a multivariate analysis, once we put in the model the sex, the OSA severity, and the SNOT-22 total score, we find that POIF and nasal patency index showed a correlation with SNOT-22 total score and with the SNOT-22 questions related to sleep, in particular, lack of good night of sleep, reduced productivity, and reduced concentration. POIF also correlated with VAS for nasal obstruction, and peak nasal inspiratory flow and VAS for nasal obstruction show to be marginally correlated. So from this preliminary study, it seems that PNIF, POIF, and POIF are not good indicators of OSA's severity, but POIF more than PNIF seems to be related to sleep-related symptoms. And this is most in line with some other papers that conclude that nasal obstruction seems to play a minor role in the pathogenesis of OSAs, but may be involved in snoring. Or with this other paper, where it is reported that reducing nasal resistances can improve, for sure, the sleep quality. It means the symptoms. But a significant improvement in objective sleep parameters remains to be proven. So the messages from these studies should be this. It seems that the contribution of nasal obstruction to OSAs is weak, though there is a contribution. In fact, difficult breathing through the nose, as demonstrated by rhinomanometry, acoustic rhinometry, and or peak nasal inspiratory flow, is associated with a reduced sleep quality, increased risk of snoring, and for some authors, also to OSAs. The objective measurement of nasal obstruction is important in the management of sleep-related breathing disorders, also because it can help to identify patients who have trouble in the future for tolerating the CPAP. Unfortunately, the measurement of nasal obstruction in patients, in this kind of patient, is still not a routine. For that, more studies should be performed to enforce the rule of objective measurement on nasal obstruction in the management of sleep-related breathing disorders. Thank you.